Cardiopulmonary case presentation. Pericarditis. It is the clinical presentation of a patient having pericarditis. Pericarditis. It is the inflammation of the pericardium characterized by sharp pain, worsened inhalation. Inflammation of the pericardium can cause chest pain. Movement of heart can cause friction between the two pericardial layers, producing a friction rub. Inflammation may cause a pericardial effusion. Symptoms. Chest pain is the most common symptom of the pericarditis. It usually feels sharp or stabbing. However, some people have dull, achy, or pressure-like chest pain. Pericarditis pain usually occurs behind the breastbone or on the left side of the chest. The pain may spread to the left shoulder and neck, gets worse when coughing, lying down, or taking a deep breath. It gets better when sitting up or leaning forward. Other signs and symptoms of the pericarditis may include cough, fatigue or general feeling of weakness or being sick, leg swelling, low-grade fever, pounding or racing heartbeat, heart palpitations, shortness of breath when lying down, and swelling of the belly, aka abdomen. Case. And here is the case presentation. A 60-year-old woman presents with chest pain. She reports the chest pain started today and describes it as sharp and brief. When she sits up, the pain improves. She has no significant past medical history, but endorses a viral respiratory infection a few days ago. On physical exam, there is no acute distress. She has a low-grade fever. An electrocardiogram shows widespread ST segment elevation and P depression in the precordial leads. Assessment and examination. Physical exam may have a fever, friction rub, pathognomonic, Kussmaul sign. It is seen in constrictive pericarditis, increased jugular venous distension on inspiration. Imaging. Number 1. Thoracic endocardiography. Number 2. Radiography. Radiography is used to rule out pneumonia or other pulmonary pathology. Constrictive pericarditis may have pericardial calcifications on radiography. Cardiac CT. It is used to confirm diagnosis if initial findings on echocardiography are inadequate. Preoperative planning for pericardiectomy. Studies. Labs. Increased erythrocyte sedimentation rate, increased C-reactive protein, may have increased troponin 1. Number 2. Electrocardiogram, also known as ECG. PR segment depression, especially in lead 2 and in all leads except a VR. Widespread ST segment elevation, upright T waves. Weeks after pericarditis, this will become inverted T waves. Classic ECG signs may be absent in uremic pericarditis. Here is the ECG. Diagnosis. Diagnosis of this case is pericarditis based on clinical findings and ECG. Differential diagnosis. Cardiac tamponade. It is the distinguishing factor. Pulses, paradoxes, and back tried on exam. Number 2. Myocardial infarction. It is also distinguishing factor. More focal ST elevation on ECG, suggestive of anatomic damage. Treatment. Non-operative. Observation and treatment of the underlying cause. Indications in case of asymptomatic or small pericardial effusion. And then there is medical treatment. Number 1. non-steroidal anti-inflammatory drugs for viral pericarditis. Number 2, steroids and immune suppressants. These are for SLE and to avoid immediately following myocardial infarction to protect from ventricular wall rupture. Number 3, dialysis. It is for uremia. Number 4, aspirin, and it is for post-myocardial infarction pericarditis. And then there is pericardiocentesis, and the indications for it are required for large effusions and cardiac tamponade. And then there is operative treatment. It is known as pericardiectomy, and it is reserved for recurrent disease. Prognosis, prevention and treatment of pericarditis. Short-term goals, and these are following: reducing pain and inflammation, treating the underlying cause if it's known, checking for complications. With constrictive pericarditis, the only cure is surgery known as pericardiectomy to remove the pericardium. This is only done when symptoms become severe. And then there are long-term goals. It takes 2 weeks to 3 months to recover from acute pericarditis. Pericarditis is often mild and goes away on its own. Some cases, if not treated, can lead to chronic pericarditis and serious problems that affect your heart. It can take weeks or months to recover from pericarditis. Full recovery is most likely with rest and ongoing care, which can help reduce your risk of getting it again. Prevention. Acute pericarditis can't be prevented. It literally can't be prevented. So you and your doctor can take steps to reduce your chance of having another acute episode, complications, or chronic pericarditis. These steps include getting prompt treatment, following your treatment plan, and getting ongoing medical care as needed. Discharge plan. Acute pericarditis should be treated with a non-steroidal anti-inflammatory drug, typically with a 2 to 4 week taper after the resolution of symptoms. In addition, a 3-month course of colchicine with weight adjusted dosing is recommended to reduce the risk of recurrent pericarditis. Home plan. Nutrition. Follow a low-fat, low-salt diet. If you drink alcohol, limit alcohol intake to 1 drink per day for women, or 1 to 2 standard drinks per day. Do not binge drink. Unless told otherwise, limit caffeine intake to 1 cup per day. This includes coffee, tea, colas, soft drinks, and energy drinks. Physical exercises. Pericarditis is a common inflammatory condition of the pericardium with multiple etiologies. Current guidelines recommend restriction of intense physical activity and return to activity. And here are the references.